In this module, we'll be discussing contraception. Contraception is the intentional prevention of pregnancy during intercourse. It can be divided into birth control, meaning using a device or a behavioral practice to decrease one's risk of conceiving, or we can think of it in terms of family planning, which is a conscious determination of when or when not to conceive. It's important to note that these decisions can be made by the woman herself or in conjunction or in collaboration with her partners. There's various reasons women, couples use contraception. The obvious one is to avoid pregnancy, also to space pregnancies, and to control the number of pregnancies. Contrary to popular belief, more than half of women of childbearing age are using some form of contraception. Based on data from a national survey conducted by the CDC, sterilization, i.e. tubal ligation, OCPs or oral contraceptive pills, long-acting reversible contraceptive like the intrauterine device or Implanon, or injectable, better known as Depo-Provera, are some of the main methods that women are using for contraception. So with this large percentage of childbearing women using contraception, it's extremely important that we as nurses understand the different types, the functions, side effects, and risk factors related to contraceptive uses. There is a national initiative through Healthy People 2020 to increase the number of pregnancies that are intended, reduce the number of women experiencing pregnancy despite contraceptive use, and increase the number of sexually active persons who are receiving some type of reproductive health services. And as you can see in these two graphs, that there is a large percentage, over half of the pregnancies in the U.S. are unattended. And when I say unattended, that includes they're mistimed or unwanted. So mistimed meaning that there was a plan to get pregnant, but the timing was off. And unwanted is self-explanatory, that the pregnancy was not a planned, nor is it a wanted pregnancy. And the other graph here of the states shows the unintended pregnancy rates by states almost about a decade ago. Women want a contraceptive method that is, first, highly effective, that has prolonged duration of action, rapidly reversible, that when they do decide that they're ready to get pregnant, that they can become fertile again. Some women want privacy of use, contraceptive that is protective against sexually transmitted infections, and easily accessible, meaning coverage through insurance, availability at pharmacy, etc. So it's our role as nurses to inform clients of the various methods, potential side effects of these contraceptive methods. All methods of contraception are considered reversible with the exception of sterilization. Reversible methods, meaning that once one stops taking the medication or using the method or no longer engages in the behavioral act, the woman is no longer protected from the prevention of pregnancy. These reversible methods can be divided into behavioral, barrier, and hormonal. Behavioral consists of abstinence, fertility, awareness, meaning knowing when your fertile days and non-fertile days are. LAM, which stands for lactation, amenorrhea, or coitus interruptus, which is withdrawal method. The second category is barrier method, which includes both female and male condoms, diaphragm, cervical cap, and sponge. Just as the name suggests, these methods create a barrier for sperm not to enter into the uterus, therefore not being able to connect with a mature egg and be fertilized. Lastly, we have hormonal contraceptive, which includes oral contraceptive pills or OCPs, injectable, which is the Depo-Provera, transdermal, which is the patch, vaginal ring, implantables, which is the Nexaplon, IUDs or intrauterine devices, and finally ECs, emergency contraceptions. Contraceptions in this category alters the negative and positive feedback loop of the menstrual cycle, where there's no longer a fluctuation of estrogen and progesterone, thus inhibiting follicle stimulating hormone to take place to trigger to the ovaries to create a mature ovum. In essence, many of these hormonal contraceptions kind of trick the brain into thinking that you're already pregnant. So there is no ovulation occurring. And so without ovulation, there is no fertilization of any egg. Another way that these hormonal contraceptions work is to make the endometrial lining unsuitable for implantation by thinning the lining or causing an inflammatory response into the uterus, which again makes for a hostile environment, not conducive for implantation of a fertilized egg. And lastly, these methods work by creating a barrier by increasing cervical mucus where sperm can no longer enter into the uterus through the cervix. So it's also acting kind of as a barrier method. And then we'll get into a couple of videos that goes into some of these categories in more depth. Let's take a review of the menstrual cycle, paying close attention to the impact and effects of estrogen and progesterone on the menstrual cycle, because that will help you to understand how these contraceptive methods work. Oral contraceptive pills, or the pill, were first introduced in the late 50s. The main mechanism of action of oral contraceptive pills is to prevent ovulation. There's different types of oral contraceptive pills. You have combined oral contraceptives, which is most common, which contains both estrogen and progesterone. We also have progestin-only pills that contains no estrogen and can be used for women who are not candidates for estrogen. So women who have a history of cancers, women who are smokers, women who are breastfeeding because estrogen decreases milk production. So there is an alternative of progesterone-only forms of contraception. I've attached a video that gives a more in-depth detailed description of OCPs or the pills for you to take a look at. So let's review. Combined oral contraceptives, those pills that have both estrogen and progesterone, have 21 days of active pills, meaning pills that contain the hormones. And then the last 7 days of pills are inactive or placebo pills. This is where the woman would have a withdrawal bleed. Oral birth control pills require daily oral administration. They should be taken roughly at the same time every day. And note that combined oral contraceptives can be monophasic, meaning that each active pill contains the same dose of estrogen and progesterone. And I've listed some examples of those. Then there can be multiphasic pills, which attempt to mimic the natural fluctuations in the hormone balance of the menstrual cycle. There can be biphasic pills that contain 2 different combinations of estrogen and progesterone, and triphasic pills that contains 3 different combinations of estrogen and progesterone. And you can't tell by doing a health history or anything like that which pill would be best for your clients. Rule of thumb, you want to start with the lowest dose of hormones first. And if a woman has what we call breakthrough bleeding in between the weeks of the cycle outside of that withdrawal bleed, then you may need to change her dosage. Women have a couple of options of when they can initiate their oral contraceptive pills. One is a Sunday start. That means starting the Sunday after the first day of your menses. So let's say your menses start on a Monday. A woman would be instructed to start her pack of pills the next Sunday. Then there's the quick start, meaning if a woman comes in and she has a negative pregnancy test, she's not been sexually active, and there's very decreased risk of her being pregnant, then she can start the pill pack the same day she gets her script. First day start is starting the first day of your menses, and then after childbirth start is for a woman who may or may not be breastfeeding, can use, if she's not breastfeeding, she can use the combined oral contraceptive and start right away after childbirth. Or if she is breastfeeding, she can start the progesterone-only pills. Now, the advantage of the Sunday start is that you know that your pills are going to start and end on a Sunday to Saturday every week, so it's just for convenience wise of keeping track. Quick start is that a woman can start right away. First day start, that you know that she's not pregnant because she's on her menses. And then after childbirth start is convenient for the woman and the provider, especially if there may be some issues with compliance and returning for their postpartum visit. There are also extended cycle oral contraceptives in which a woman takes active pills for 12 weeks consecutively, and then the 13th week, she takes the placebo pills. This allows for a woman to have withdrawal bleeding only approximately 4 times a year. Below, I've listed some examples of those extended cycle oral contraceptives. Women who are candidates for this type of pill are women with endometriosis, who tend to have painful menses, women who have any other medical condition that are aggravated by their menses, like PMS or PMDD, and then women who just desire fewer menses a year. Now, there is a myth or concern that a woman should have a period or should have a bleed every year. And what happens to that lining if you're constantly taking an active pill for 12 weeks? Well, it's not medically necessary for a woman to shed every month. And the lining ends up being so thin, the endometrial lining doesn't thicken because of the continuous intake of the hormone estrogen and progesterone, that there is no buildup of the lining. In fact, the lining becomes thin and there is little to no blood to shed. In addition to instructing your clients on how to take the pill, it's extremely important that you discuss and make sure that your clients understand the signs of potential complications with combined oral contraceptives or oral contraceptive pills. And we use the acronym ACE in teaching. Abdominal pain, chest pain or any shortness of breath, headaches that are severe, sudden, persistent, that do not go away with Tylenol or ibuprofen, any visual changes, and if there's severe leg pain, cramps, or warmth in the leg, they should notify the provider immediately and stop taking the pill. In this video link, I want you to pay close attention to the 2 non-oral hormonal contraceptives that are being discussed. First, the vaginal ring or NURS ring, and the transdermal patch or ortho-evra. There's also mention of a progesterone-only pill, but we'll discuss that in a couple of slides later. Know that with the vaginal ring, that it's self-inserted and self-removed. It remains in the vagina for 3 weeks, and the 4th week, the ring is removed and discarded, and withdrawal bleeding should happen. Note that if a woman finds that her ring has been removed or it slips out of place and it's been greater than 3 hours, that she should use a backup method of contraception, i.e. a condom, for the next 7 days. In the next couple of slides, we'll be discussing progestin or progesterone-only contraceptives. These are contraceptive methods that only contain the hormone progesterone. There is no estrogen in these methods. And these are ideal for candidates who where estrogen is contraindicated. So women who have heart problems, women who are older, 35, and smokers, and breastfeeding moms, progesterone-only contraceptive methods would be ideal for them. But any woman can use progesterone-only contraceptive with a few exceptions. And remember, progesterone alone is okay, not estrogen. And if you recall back in the women's health module where we talked about hormone replacement therapies, that estrogen alone cannot be given, especially for a woman who still has her uterus in place, because estrogen increases that woman's risk of uterine cancer. Just like with the oral contraceptive pills, women who have IUDs inserted also need to be counseled on signs and symptoms of complications that need to be addressed immediately. And we use the acronym as PAINS. If a woman is still having her menses with an IUD, for instance, if she has the copper IUD inserted, if her period is late, or if she's having some abdominal spotting in between her periods, she should notify her provider. If she's having severe abdominal pain, if she's having painful intercourse, which is dyspareunia, if she's been exposed to any type of infection, so any sexually transmitted infection, chlamydia, gonorrhea, BV, any of those things, she should notify her provider, because again, remember, there is a string that hangs outside of the cervix in the vagina. And if a woman has a vaginal infection like a gonorrhea or chlamydia, that infection can adhere to the string and ascend up into the cervix, into the uterus, etc., all the way up into the fallopian tubes, which could lead to PID, pelvic inflammatory disease. If she's having overall not feeling well, fever, chills, that's not related to a common cold or a upper respiratory infection, and if her string is missing or she notes that it's shorter than usual, and that women who have IUDs should check their strings every month after their menses. Next, we'll discuss single contraceptive implants, better known by their brand names Nexaplanon or Implanon. And these are one rod matchstick size implants that are inserted into the inner arm, left in for 3 years, containing progesterone-only, a synthetic version of progesterone, and it is effective in preventing ovulation, basically tricking the body again and believing that it's already has a fertilized egg. Here I've noted some average insertion and removal time. This is another long-acting contraceptive like the IUD because it is effective for years, and it has a slightly better effective rate than the IUD. And women who are lactating can, again, use any of these progestin-only contraceptives. Here's just a chart comparing the various types of contraceptive methods. This can be helpful in teaching when you're discussing with the client and helping her make the decision on which contraceptive method is best for her if she's choosing a hormonal contraceptive method. In this video, you'll learn about various barrier methods used for contraception. Barrier methods contain no hormones, so no estrogen or progesterone. Their main purpose is to block or kill sperm and prevent it from entering through the cervix, up the uterus, into the fallopian tube to meet the mature ovum or egg. And so barrier methods can be used in combination with hormonal contraceptives for an added protection. And it is to be noted that none of the hormonal contraceptives that we've discussed, combined contraceptives or progesterone-only contraceptions, even the copper T, none of them prevent or protect against sexually transmitted infections. And so when you're counseling women, you have to keep that in mind, and that a barrier method, preferably condoms, female or male, is their best option in protection and reducing their risk of contracting a sexually transmitted infection. So once you've listened to and viewed this video, I've kept some slides in just as a review of those various barrier methods. So including condoms, diaphragms and cervical caps, cervical sponge are all listed in the slides preceding this video. Another method of contraceptive that can be used that doesn't require hormones is called lactational amenorrhea method, or the LAM method. This is a temporary method that can be used by breastfeeding mothers. It works by inhibiting estrogen production. The hormone prolactin that's produced when a mother is lactating, when she is breastfeeding, stops the production or prevents the production of estrogen, therefore suppressing ovulation and delaying the menstrual cycle. This method only works if a woman is exclusively breastfeeding, meaning that she's providing no supplementation of formula or water or any other feeding method to her newborn. She has to have had no menses, no period since delivery, and that her baby is younger than 6 months. And it's temporary because at 6 months of age is when it's recommended that you start to introduce solids into the newborn's diet. Therefore, she will no longer be exclusively breastfeeding. She has to be breastfeeding at least every 2 to 3 hours, or pumping, so that that prolactin production continues. So again, lactation amenorrhea can be effective if the mom is exclusively breastfeeding, has not had a menses since she's delivered, and her newborn is younger than 6 months. Now we'll talk about permanent sterilization in the forms of tubal ligation, vasectomy, and a procedure called Induced. First, we'll talk about the two operative sterilizations: tubal ligation for females and vasectomy for male. With all of these types of contraceptive or sterilizations, the goal is to prevent pregnancy permanently. So contrary to what some people believe, that tubals can be reversed, that's not the intent. And so a woman can still get pregnant, most often through artificial insemination, but not through the fallopian tubes itself if she's had a tubal ligation or the Induced method, which we'll talk about in the next slide. I have provided 2 videos explaining each method, tubal ligation and vasectomy. It should be noted that men who have a vasectomy will still have an ejaculation, because the seminal fluid, which transports semen through the penis, is still released. The seminal fluid after vasectomy no longer contains sperm. So vasectomies have no effect on erections or ejaculation of semen. Here's a video explaining the non-operative sterilization for women called the E-Sure method. So this method can be done just like a vasectomy in a provider's office and does not require hospitalization or outpatient surgery. Lastly, we'll talk about emergency contraception. Emergency contraception should be used after unprotected intercourse or if a contraceptive method has failed. For example, the condom breaks or a woman has missed a sufficient amount of her birth control pills. Should be taken within 5 days, and it's most effective when taken as soon as possible. I've attached a link to a video that describes and demonstrates the mechanisms of actions for emergency contraception. It should be noted that emergency contraception is not intended as a regular form of birth control. It's available by prescription and now over the counter for women at the age of 15. It used to be women over 18, but now the age has been reduced to age 15. So there is no state laws that require parental consent for prescriptions of Plan B or any other type of emergency contraception. Again, it doesn't protect against sexually transmitted infections, and it should be noted that it's an important aspect of sexual assault treatment. So women who have experienced rape or sexual assault should be offered emergency contraception. Again, it is not an abortive pill and will not affect an already existing pregnancy. When helping a client choose a contraceptive method, it is important that we as nurses elicit and respect the patient's choice, noting the goals for fertility control, talk about the anticipated levels of correct and consistent use, and making sure that our clients are comfortable with the mechanisms of actions. For example, if a woman has expressed that she's not comfortable inserting her fingers in her vagina, then a NuvaRing or a vaginal ring wouldn't be a method of choice. Would she have difficulties checking the string placement if she had an IUD? So we have to take those things in consideration. Recognize any of our potential biases regarding contraceptive use in general, and note that women's needs change over time. So you may have a client who oral contraceptive pills may have been her method of choice in her early years, or the Ortho Ever patch, and now she's looking for something more long-acting to space out or prevent pregnancies. So when we're discussing contraception education with our clients, we have to keep those things in mind. Regardless of your stance, as nurses, we need to know what the definition of induced abortion is. So induced abortion is the purposeful interruption or cessation of a pregnancy that's less than 20 weeks. And so there's two types of abortions. Elective, which is performed at the woman's request, meaning that there is nothing wrong with the fetus, or there is no detriment to either the woman or fetal health that would require or suggest an abortion. And then there's a therapeutic abortion, which is performed for medical reasons. Either there's a maternal risk or there's a fetus that is incompatible with life, meaning that it would die once it's born. You should also know that nurses have a right to participate or not to participate in abortive procedures. And on the next slide, I give you the ANA, American Nurses Association's Code of Ethics, which supports that. It is up to the nurse to inform her employers of her comfort level with participating in abortions or taking care of a patient who has recently had, whether it's elective or therapeutic abortions. We've talked about a lot of different methods of contraception, so I wanted to just insert here a review on contraception and just pick it up on key notes or key things, mainly the methods of action that prevent a pregnancy with these various contraceptive methods. Infertility. Infertility is the inability to conceive and maintain a pregnancy after a year of unprotected sexual intercourse. There are two types of infertility. Primary infertility, where for a woman where she has never been pregnant, so never been able to conceive, and secondary infertility, where she has had a pregnancy and now finding it difficult to conceive. Infertility affects approximately 10 to 15% of couples in the States. Most often, the cause can be identified. It can be related to female issues, male issues, or a combination of both. As providers, we need to be aware of not only the physical, but the emotional and psychological stress that infertility can have on a couple, and also include financial stress. Here I've just listed various types of factors or issues, male and female, that can affect infertility. Ovarian issues, uterine issues for the female, and male issues related to anywhere from underdeveloped testicles to sexually transmitted infections, changes in sperm, etc. There are various tests that can be done on both the female and the male and the couple to help in assessing the cause of infertility. For the female, anywhere from hormone analysis to see if hormone levels are high or low enough to elicit the negative and positive feedback loop to initiate egg production and ovulation, checking of the endometrial lining, making sure that once an egg is fertilized, that the lining is sufficient enough for implantation, doing various types of scopes to test if there's any blockage in the fallopian tubes, etc. For the male, a semen analysis to examine the sperm, one, to look at sperm count, to look at sperm shape, and look at sperm mobility. So if there's not enough sperm, that would impact infertility. If the sperm are not mobile, if they're not moving, then they can't make their way up through the vaginal canal into the uterus to the fallopian tubes, and if there's some deformity to the sperm cells themselves. A couple can do a post-coital test, meaning that the couple would have intercourse, unprotected intercourse with no lubricants, and then the woman would come into the office and a sample of her cervical mucus would be examined to see how well the sperm interacted with the cervical mucus. Was that a hostile environment? Was the cervical mucus too thick and that it was preventing the sperm from um, being more mobile, sorry. There are various interventions that can be initiated in helping a couple conceive and maintain a pregnancy. There are medical interventions that are geared towards treating any ovulatory dysfunctions, meaning stimulating medications to stimulate ovulation, medications that enhance the follicles to mature. So medications like Clomid are popular. Um, Injections of FSH or gonadotropin releasing hormone or even metformin have been used. And here I've listed um, some of the common assisted reproductive therapies. I won't read them to you, but just be familiar. We're most often familiar with IVF, but there are other types of assisted reproductive therapies to be noted. And again, keeping in mind when you're caring for, if you're working in an infertility clinic, keeping in mind the psychological, emotional, and financial stressors that these couples are dealing with. And that concludes the module on contraception.